Thank you, Dr. Andrew Wright, for talking to us today about surgical education, simulation, and robotics. Can you give us a little background first?
Sure. So I'm a general surgeon. I do mostly minimally invasive surgery at the University of Washington in Seattle. And I work in our simulation lab, which is called ISIS, the Institute for Simulation and Interprofessional Studies. And I also work with our biorobotics lab.
Cool. And so you've been an attending surgeon for a number of years now. Tell us what you think about just the model for training in the U.S. We've had a very we've had one model for quite a long time. What do you think of that model? Was it a good model?
Yeah, so the model we use for residents really dates back to Halstead and with only very minor modifications. So it's an apprenticeship model. It's based on the number of years you spend. It doesn't really look at all about how skilled you are, either technically or your cognitive abilities. It's just you put in the 5 years and you're done.
Right.
And I think that's broken. It's not something that's going to be sustainable, especially given the explosion of subspecialty surgery.
Mm-hmm. So what elements of that model do you think we should keep, and which things should we change?
So I think the first thing that we should keep is our high standards. And as a profession, surgery has always had high standards. We've produced excellent graduates for decades and generations, really. So we can't give up on those standards, but what we can do is use sort of modern educational theory and modern technology to build the next generation of surgeons more efficiently, with better patient safety, and with real monitoring of their abilities and outcomes.
And what theories come to mind when you say taking advantage of new theories?
Sure. So the traditional model, and most of your viewers may be familiar with this, but the see one, do one, teach one model. And we now know that that's not really the best way to learn. One, for patient safety. But just from adult learning theory, the best way to learn is through deliberate practice over time, slowly building autonomy and slowly building abilities, so that by the end result, you're able to do the whole procedure. But it really needs to have a more thoughtful process for how we teach someone how to do an operation or how to care for a patient.
Mm-hmm. And there's some push here and there for a competency-based advancement. Is that something you see as an important part of a new model?
Yeah, so I would love to see a competency-based advancement. The downside to competency-based advancement is that logistically it's really, really hard. You'd have residents coming in, leaving, moving to different services, not based on a calendar model, but when they're ready. That only works if you're able to run a system with or without the residents being there. And so I think that we're going to reach some sort of modified competency-based model. But the full competency-based model they're trying in Toronto, for example, in orthopedic surgery, it works great for the residents. It's a nightmare for the program directors.
I imagine. Okay. And the ones who are in that program, I think I recall learning that they actually advance faster than they do in our time-based models. Is that what you would predict if people were being advanced based on competency?
So I think that based on competency, there might be some people who move through very, very quickly, and there may be some people that take longer. It really depends on the individual and their skills. Mm-hmm. I think the two reasons people move through faster on the Toronto system, one is a competency-based model, but the other is the fact that they've moved to a lot of advanced practice providers, AR&Ps and PAs, that are doing a lot of the work that we rely on our residents to do. So the residents' time is much more spent in educational activities and less in the service-based opportunities that we really rely on our residents in this country for.
Right. So is anybody experimenting with those models here? All I've heard about is Toronto and orthopedics.
Yeah, that's. I know that in Toronto they're looking at moving it to other specialties, but they've had took a lot of funding and resources to accomplish that, and I don't think anybody in the States has started to do that yet. At least not that I know of.
Can you think of other major innovations that you are seeing put in here and there that are changing the or adding to the model that we are familiar with?
Well, obviously, the thing that I'm really working on, and that's near and dear to my heart, is the idea of simulation and trying to teach residents both the cognitive and the technical skills outside of the clinical environment. It doesn't replace the clinical environment. You can't do everything in simulation and expect to practice as a surgeon. But what it does is it gets the prerequisites, as you will. You get the skills, you get the knowledge, so that when you see that patient for the first time, it's a much safer environment for the patient, and it's a much more effective learning environment for the resident.
Where would I find the best literature about simulation and training in surgical training?
So there's a whole lot of literature. There are hundreds of papers a year now. Probably the best papers are some of the VR to OR papers by Seymour or Grantov or others that really show some transfer from the simulation lab to the clinical environment.
What's VR to OR?
So in other words, that there's a lot of folks working on simulation, but very little evidence that it actually improves, for example, patient safety. Mostly because those studies are so hard to do. So there are a few studies, Seymour's study in particular, where they showed that training in the simulation lab corresponds to improved safety in the clinical environment, in the operating room. They call it VR to OR because in that particular study they used a virtual reality simulation model. But it doesn't have to be virtual reality. In fact, I've done a lot of work now in developing countries in simulation where we do very inexpensive non-virtual reality simulation that works very, very well.
Okay. So what else about simulation do you want to tell us about?
I think the one big misconception is that simulation is only for technical skills. That simulation is for learning how to sew or learning how to do an anastomosis. I think the big excitement in the simulation world is around communication and improving team communication with interdisciplinary teams. So it's not just the surgeons, but you have surgery, nursing, anesthesia, PAs, pump techs, all in the same room together, learning how to communicate better.
Team training, yeah.
Team training, exactly.
Yeah. I also saw an app, Touch Surgery, that was teaching the cognitive steps of surgery. I thought that was interesting.
Yeah, the idea of things like that is that if you learn the cognitive steps, then when you go into the operating room as a trainee, you're not thinking, okay, what's the next step? At the same time, you're trying to figure out what do I do with my hands. So you can concentrate on one thing at a time.
Right. What about robots? Are you integrating robots into the training of general surgery residents where you are?
So I am a big believer in robotics in the future. I have to show my bias is that robots now are not where I would want them to be. And at least in general surgery, I don't see any role for robotics. I did about 150 cases with the robot early in my career, and I gave it up because it only added more OR time and more expense without improving patient outcomes. So that being said, I work with our biorobotics lab. In 50 years, I don't think you will do any case without a robot. But I don't think it's going to be the intuitive Da Vinci. I think it's going to be something else. Yeah. We have worked with our urology colleagues. One of my friends, Tom Lenve, is working on a fundamentals of robotic surgery, for example, as a multidisciplinary, multi-institution program similar to fundamentals of laparoscopic surgery. So I do think there's a role for simulation in robotics training. I just don't think it's in general surgery yet.
Okay. So do you think the robots were sort of pushed out for mass use too early?
I don't know about too early. The robot, I think, first of all, the thing to know about the Da Vinci is that it's a misnomer. It's not really a robot. It's a telemanipulator. It only tracks your movements and may subscale and may filter some tremor out, and the ergonomics are nice. But a robot actually does something on its own. If you look at an industrial robot, it's building something on the assembly line, and the human's not directing its every motion.
Good point.
So the Da Vinci, it allows you to have a little bit more dexterity in a laparoscopic field. It allows you to work in a narrow space, which might be handy in the pelvis for GYN or urologic cases. But when you're talking about real surgical robotics, what you're really talking about is automation. so that as a surgeon, I sit at the console and I direct the robot, okay, sew this to that.
That'd be
and
nice.
It does it. It's like point and click surgery.
Mm-hmm.
And I think that's where really robotics is going to come into play.
Mm-hmm. Interesting. I hadn't thought about that sort of in advance. Okay, what else? What else about robotics, or anything else you'd like to talk about?
Sure. Robotics, I think the innovation that we're going to see in robots in the next few years is going to be just on the scale of smaller and less expensive. And hopefully now that some of the patents are running out, that we'll see some competitors to Intuitive.
Yeah, bring the price down.
And bring the price down. And there hasn't been a lot of reason to innovate for Intuitive because they've got this great business model. And now that their IP is running out, hopefully we'll see some competitors.
I hadn't thought that was the reason there's no competition. There's some patents that are protecting it.
There was a big battle between Intuitive and Computer Motion a few years ago, and Intuitive won the battle. And since then, there really hasn't been any competition in the market space. So
I see.
Hopefully that'll improve. In the simulation world, I think the big innovations are going to come not around resident training, but about surgeons in practice. And using simulation, much like it's used in the aviation industry, for maintenance of certification. That every year you're going to do training, whether it's team training, whether it's technical skills training, whether it's training on a new technology or new device. I think the real model for that actually is the Harvard system, where they're actually training not residents, but they're doing team training of attending physicians and teams, and actually giving the surgeons a malpractice insurance discount for completing the simulation. So it's trying to tie simulation to licensure, to insurance, and trying to drive better patient safety.
Interesting model. Very good. Well, thanks so much for talking to us today, Dr. Wright.
Oh, my pleasure.
Hope to talk again soon.
Anytime.
Take care. Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.